the vast majority take place in the US, 81%, followed by Europe, 16%. Most trials focus on, you can imagine what? Cancer. It's not only research priorities that are heavily driven by the economic interests of the industrial North, but also the products of research. According to Genomics and World Health, of the 1,233 new drugs marketed between 1975 and 1999, only 13 were approved specifically for tropical diseases. Furthermore, of these, 6 were developed by WHO, UN Development Program, and World Bank supported special programs. Some observers, and particularly those who come from what I'm now coming to call the 90% world. I mean, we've been struggling for a long time. Do we say developing world? Do we say 2/3 world? But I'm beginning now to be persuaded that 90% world in this context makes sense. Some observers argue that the bias toward developed nations extends to the way that we define and respond to ethical dimensions of research and distribution. Commenting on the way the ethics of HIV/AIDS research has been discussed, Zulfikar Buddha observes, while issues of study design, ethical review, standards of care have been highlighted, and he believes that's a very positive thing, the underlying socioeconomic deprivation and inequalities are largely ignored. While the concerns about research in developing countries have brought a welcome focus on this long neglected area, the focus has been on regulatory issues, rather than on the basic problems that underlie the inequities in health and human rights in developing countries. Some critics worry that inattention to vast disparities in public health infrastructure globally goes even further, potentially masking recognition that genomics has the potential to divert precious resources away from the core issues of global public health: provision of clean water, safe food, proper sewage disposal, decent housing, access to maternal and child care. That question of contests of resources is always a critical one, and it was brought home to me in discussions following the tsunami and responses to the tsunami, because they were interviewing aid workers around the world, and one from Africa, from East Africa, said the outpouring of support, of financial assistance, it's wonderful, it's moving, it's wonderful. He said, but I gotta say, we have a tsunami a week. I think it's important to say that we don't need to look only to the developing world to find fear that the pursuit of genomic advances will exacerbate existing injustices in the current healthcare system. Audrey Chapman, who is a bioethicist with the American Association for the Advancement of Science, captured well the risks in our current situation in the United States in a recent article on the ethics of inheritable genetic modifications. That is, technologies that would allow for the modification of a set of genes which then would be available to transmit to one's offspring. 4 factors, she argued, lay the groundwork for concerns about assuring equity in access to the benefits of genetic therapies: the lack of a system of universal health insurance, patterns of inequalities in access to healthcare in the US, a projected scarcity of the availability of genetic services relative to demand, and the likely high cost of such interventions. Chapman notes that problems in obtaining access to healthcare are unfairly distributed throughout our society. Blacks, Hispanics, and other minorities tend to receive lower quality healthcare than whites do, as a result of lower incomes, inadequate insurance coverage, and the absence of doctors in their places of residence. Minorities are far more likely to be uninsured as compared to whites. Minorities comprised 46% of the uninsured in 2000, even though these groups represented only 24% of the United States population. In 2001, 37.7% of the uninsured were Hispanic, and 20.2% were African American. And that compares to 14% who are white. She cites also a report issued by the Institute of Medicine in 2002 to argue that a systemic therapeutic discrimination affects the health care that minorities currently receive. A review of 100 studies conducted over the past decade concludes that racial and ethnic minorities in the United States receive notably lower quality health care even when they have the same incomes, insurance coverage, and medical conditions as whites. The differences were especially significant for high technology interventions, for example, organ transplants and open heart surgery. The IMO report attributes the disparities to subtle racial biases, to the nature of healthcare facilities available in specific geographic areas, and lower rates of long-term relationships with providers. There was also an earlier Institute of Medicine study in 1999, which was called The Unequal Burden of Cancer. And that argued that there are similar concerns about inequalities in terms of research priorities. It concluded, for example, that NIH funding for research targeting minority and medically underserved populations was both inadequate and unequal in comparison to research targeting non-minority populations. I think that Chapman is correct in assuming that current limitations on access to healthcare, particularly high technology interventions, will also likely operate with respect to genetic technologies. Enhancement technologies, for example, the ability potentially to give one's offspring enhanced physical, emotional, or intellectual capabilities. They are likely to be very costly, and like in vitro fertilization and other reproductive technologies currently, they're likely to remain available in the almost wholly unregulated private sector. And they're going to be available to those who are willing and able to pay. Since the effects of providing your child with the best possible natures are cumulative, then gaps have the potential to grow generationally. Even if universal health coverage were to be undertaken, underwriting access to some forms of genetic services, for example, gene therapy for muscular dystrophy, as Chapman points out, the IMO report suggests that the very groups who currently lack access to medical care, that is, the poor and ethnic and racial minorities, are likely still to be disadvantaged. If concerns about a growing genomics divide, whether we're talking locally or globally, are at all founded, they join more general concerns about growing gaps between rich and poor, between prosperous nations of the industrial north and sustenance-level nations of the south, concerns that have long been visible in Roman Catholic social teaching, and are visible especially in contemporary documents such as Solicitudo Rei Socialis and Centesimus Annus. In their pastoral letter on the economy, the U.S. Catholic bishops make inequity the hallmark of economic and social disease. The obligation to provide justice, they write, for all, means that the poor have the single most urgent economic claim on the conscience of the nation.